Today's conversation, we are going to focus on disorders of sight, those disorders that become an increasing worry as we personally age or as we take care of family members who are losing their sight. A survey in 2020 of blindness in people aged 50 years and older found that globally, the number one cause of blindness was cataract, affecting 15.2 million people, followed by glaucoma, 3.6 million, age-related macular degeneration, 1.8 million, and diabetic retinopathy, just under 1 million. In total, 21 million people globally, 51 and over, suffered from blindness. In an upcoming episode of Growing Older, Living Younger, I talked with demographic futurist Bradley Sherman about the aging of our global population. And here are some statistics from his book, The Super Age. He writes that by 2030, which is only 8 years from now, at least 35 of the 195 nations on this planet will have at a minimum 1 out of 5 people over the age of 65. And by 2050, 1 in 6 people worldwide will be over 65. The numbers are projected to be 1 in 4 in Europe and North America. When we consider that the incidence of cataracts, glaucoma, macular degeneration, and diabetic retinopathy increases with aging, the medical, societal, and economic implications are staggering. Today, our focus will be on glaucoma, what it is, who is at risk, and what prevention and treatment strategies may be available to us. My guest today is glaucoma specialist, Dr. Daniel Laroche, Director of Glaucoma Services and President of Advanced Eye Care of New York, and a clinical assistant professor of ophthalmology with the Icahn School of Medicine at Mount Sinai Medical Center. Dr. Laroche received his bachelor's degree from New York University and medical doctorate with honors in research from Weill Cornell University Medical College. He completed his medical internship at Montefiore Hospital, his ophthalmology residency at Howard University Hospital in Washington, D.C., and his glaucoma fellowship at the New York Eye and Ear Infirmary with Glaucoma Associates of New York. Specializing in the diagnosis and treatment of glaucoma, Dr. Laroche has performed thousands of glaucoma surgeries using the latest techniques of medical, laser, and surgical treatments for glaucoma. Welcome, Dr. Laroche, to Growing Older, Living Younger.
Thank you so much for having me.
Well, I know that there are many different types of glaucoma, so I wonder if you could begin by telling us exactly what is glaucoma.
Glaucoma is when you have an optic neuropathy. That's damage to the optic nerve inside the eye. I have a little model here for your audience. Here's the eyeball, and in the back of the eye, you have an optic nerve here that connects to the brain. And when you have damage to this optic nerve called cupping, that can lead to slow loss of vision and blindness. Now, the most common cause of the cupping is elevated eye pressure. If you touch the eye, the mean normal intraocular pressure is 15. But with age and age-related changes in the eye, in some people, that pressure can drift up to about 18 or higher. The mean intraocular pressure in patients with glaucoma is about 18 or higher in those patients. And that's what causes the damage inside the eye. So it's very important for everyone to get their eyes checked. But glaucoma is an optic neuropathy of the eye, usually age-related. Okay, with aging occurs with aging, that can lead to slow loss of vision and damage to the visual field.
Okay, so you mentioned aging, but who else would be at risk of developing glaucoma? And are there special situations or special people who may be at increased risk?
Well, age is the biggest one. Usually around age over 40 to 50. When cataracts start, the slope and curve goes up. That's when the slope and the curve of glaucoma goes up as well, because you have enlargement of the lens inside the eye. And when you have enlargement of the lens, that compresses the drain and contributes to elevation of the eye pressure. Certain groups are at higher risk. African Americans, Afro-Latino patients are at risk, people with a history of trauma to the eye. Those are the biggest risk factors.
And are there things that people can do to avoid, increasing your intraocular pressure?
Well, the most important thing is to get an eye examination, okay, particularly over the age of 40, because by that time you start to need reading glasses. And so your near vision may be affected and you're going like this, stretching your arm to read. And so you want to get checked to see if you have presbyopia. Once you're getting checked for presbyopia, at the same time, they'll check your eye pressure because you cannot feel the eye pressure in the eye. And if your eye pressure is like in a 15 range, that's usually a pretty safe range. If it's 18 or higher, then they may need to do some additional tests. Check the lens for cataract formation. Dilate the eyes to check the optic nerve and take a look at that. Check the macula, which could be affected with retinopathy and macular degeneration. And then if there is some suspicious damage to the optic nerve as cupping, they may need to do some additional tests like an OCT that looks at the thickness of the nerve tissue inside the eye. Optical coherence tomography.
Okay.
That's an imaging machine that images the retina and optic nerve of the eye to look for actual changes in the size of the tissue. And also a visual field that actually looks at the peripheral vision. And so that's the most important thing. Now, what else can you do at home for yourself? What's very important is a healthy diet. Okay, lots of salads, lots of vegetables, okay, that has a lot of antioxidants, vitamin A, vitamin C, vitamin E, zeaxanthin, okay, antioxidants. So green vegetables, very healthy. That helps protect your eyes and your body overall. Exercise. Walking 30 to 60 minutes a day. That helps to improve the circulation to the eye. Improving circulation to the eye and the body helps to keep the eye pressure low. And then also meditation. Meditation where simple things like for 15 or 30 minutes a day in a dark room, take some deep breaths, listen to some soft music, breathe through your nose. For like 10, 15 minutes, deep, slow breath. That lowers your eye pressure by about 20%. That lowers your blood pressure by about 20%. That lowers the cortisol levels and stress hormones in your body. So, and that's very important for your mental health as well. So those are things that you can do at home to help reduce the risk of glaucoma. If you have glaucoma, to help lower the eye pressure and help better take care of yourself overall.
Actually, I'm really familiar with the concept of needing, amongst other things, lutein and zeaxanthin, which are very prominent in the macular area of the eye. I'll relate a little personal experience. I guess about 8 years ago, I was seeing my ophthalmologist for a regular checkup, annual checkup, because I've had severe myopia since I was a kid. And he horrifically said to me, "Oh my gosh," he said, "you have immediately got to go and see my colleague at the eye center." And it turned out that without knowing it, there was no indication to me. I had a retinal bleed. In other words, I had wet macular degeneration, which he said was on the basis of, severe myopia in the right eye. And that was a fascinating experience for me. It was actually quite horrific because I saw the physician later that afternoon, ended up having all the investigations. It ended up that his diagnosis was correct. They gave me an intraocular steroid injection, which was kind of mind-blowing, and then did the laser treatment where I think they put fluorescein in and then attack the blood vessels. And I went home feeling a little bit like the Unabomber, totally unexposed to any kind of light, spent the weekend at home terrified at the thought of losing my vision. But one of the things that they told me about was the AREDS study, or the AREDS 2 study. And so I began taking a formula, which I still take religiously today, based on the AREDS formula that, provides lutein and zeaxanthin, among all the other things that you mentioned. And every day I say, a grateful word to the universe that my left eye is fine. So that's sort of my personal experience with prevention of eye disorders. And the other aspect that I wanted to talk about, I understand that in many cases, glaucoma is considered a familial disease. So, for example, my late grandmother the memories that I have of her, her last sort of couple of years, was every evening and every morning helping her instill her glaucoma drop into her eyes to keep her glaucoma under control. So there is obviously a familial aspect to that, and I want to ask you a little bit more about that. But I understand that there is also, for certain forms of glaucoma, there's about a 5% group that actually the, what is it called, primary open angle glaucoma is actually attributable to single gene disorders.
Yes, there are some genetic genes that have been found associated with primary open angle glaucoma, optineuron gene and certain other genes. Those are rarer in that respect. The bread and butter open angle and narrow angle glaucoma is actually due more commonly to enlargement of the lens inside. This is the lens inside the eye. And this lens inside the eye, which develops a cataract with age, but not only can it develop a cataract with age, it actually can become larger with age. And with that, that's not as much as a genetic correlation. That's the most common thing that we see in our practices because we don't routinely test for genes and genetics in adult glaucoma. That's more so for pediatric and younger glaucoma, where children are born with glaucoma, or what happens at a younger age, that we have a higher sensitivity and specificity for certain genes in that population. But that's very much less common. In adults, though, this enlargement of the lens that takes place, I see that run very commonly in families. Brothers and sisters. Whenever I have a patient that has glaucoma, I'll say, make sure you get all your family members checked, your brothers, your sisters, your parents, your cousins. When you have a family get together, let them know that you have glaucoma and they should get their eye pressure checked, get their eyes checked, get their optic nerve checked in that respect. And what I find in my practice is the common thread in many of these families is the large lens in the eye. Some people have a larger lens development that occurs that could be clear too. Not even cataractus. They could have 20/20 vision, but they have this large lens that leads to high pressure inside the eye. We have to intervene earlier with surgery to help restore the pressure being lower and actually prevent blindness from glaucoma. And actually, in some cases, cure glaucoma. This is a type of earlier glaucoma you can cure with earlier cataract surgery or lens removal.
So if one has a family history, a parent or a sibling with glaucoma, obviously you're going to be more prone to go and get your eyes checked. But it's amazing how many people don't do what they know they should do. Are there any sort of early indications, visual indications that people might be aware of? I guess narrowing of or closing in of the visual field, is that something that people can detect in themselves?
Glaucoma is called the silent thief of sight. And the reason for that is because when you have the elevated eye pressure and it's damaging your eyes, you don't feel it. It can make you lose 90 to 100% of your vision before you notice it. And then when you do notice it, you'll notice it just incidentally by maybe covering one eye one day and saying, you know what, I just happened to actually cover my eye and I noticed I can't see out of that eye. And then by the time you come in, you'll be like completely blind in that one eye and it's irreversible, okay? And I've seen patients present that way. And so that's why I'm glad you're doing this story. And one of the reasons why I'm here is because I want to get that message out about getting your eyes checked. Just like you get your annual health check once a year, it's very important to get your eyes checked once a year to check for these type of things, for cataracts, glaucoma, retinopathy, because there are so many things that we can do now with earlier surgery, earlier laser surgery, even for retinopathy like you had and you described, to help preserve your vision.
Yeah, it's really interesting. And actually, you've given me a little sort of prod because, you know, I normally have an annual checkup by the retinal specialist because of the macular degeneration. And with COVID, I've kind of delayed it and put it off. So I'm going to phone and get my appointment set up.
Talking about COVID, you're not alone.
Yeah, I know, it's terrible.
A lot of people, you know, that are in the 70 or 80 years of age category are in a high-risk category for COVID. And they're scared to come out, and that's understandable. So the key thing is, one, make sure you get vaccinated. If you're double vaccinated and boosted, those people have the lowest risk of being hospitalized for COVID. That's one. Two, doctors' offices now, we know how to manage patients and see patients in this pandemic. We wear masks, you know, In the office, we wear these masks. We have plexiglass. We have spacing. So it's safe to go out to your doctor now.
Mm-hmm.
So please go out and get your regular checkups and your maintenance checkups. And the reason it's important because I have seen some patients during the pandemic that didn't come back for a couple of years, and they did suffer some, irreversible vision loss because their pressures weren't controlled. They didn't get the surgery that they needed, or they weren't able to get certain medications that they needed. They did progress. And, that's preventable. It is preventable. Yeah. So make sure you get your eyes checked out.
Now, I also read that African Americans are 6 to 8 times more likely to develop certain forms of glaucoma, and other forms are much more common in Asian populations. So on what basis do you think that occurs? It's got to be some kind of genetic underlying complex of genes or something that would be so specific to different ethnic groups.
Part of it is genetics, but part of it is lack of access to care. Within the African American community in particular, there's a 4-time higher prevalence of glaucoma and 10-time higher rate of blindness from glaucoma. And the reason for that in the United States, there are 40 million African Americans in the United States, but there are only 400 African American ophthalmologists and even a smaller number of glaucoma specialists. And the reason for that is because of the history of America's history of slavery, segregation. I'm part of the first generation of people of color actually getting trained to become an ophthalmologist. And there's very few of us. And so that's why my offices, being in Harlem and Southeast Queens, we're very busy. I do 15 to 20 surgeries a week because the community is extremely underserved. Within the United States, although segregation is illegal, a lot of residential neighborhoods are very much segregated. And you have a shortage of healthcare facilities and specialists in those segregated Black communities. So a lack of access to care, lack of information, lack of resources, lack of insurance, all of these lead to a cascade of delayed presentation, increased risk of blindness. By the time patients sometimes will come in to see me with glaucoma, they may have lost about 25 to 30% of their vision already. In areas like Europe, for example, they have a universal healthcare system in England and a more homogeneous population, and people will present with glaucoma much earlier at, just with high pressure in the eye and no loss of vision or very mild loss of vision. So those are some of the factors that are behind those disparities. And within the Asian population, there's a similar situation as well, because in Southeast Asia, there's a lot of poverty in Southeast Asia and a shortage of eye specialists as well. They have a higher incidence of angle closure glaucoma. That's the large lens related part, closes off the drainage angle. There's genetics that's part of that as well, lack of access to care. So moving forward, one of the things that we need to do is to train more surgeons, train more diverse surgeons that are reflective of those communities, because people from different ethnic communities tend to practice within their communities. In New York, we have a very diverse population. We speak 110 different languages. And we have different communities like Chinatown, Little Italy, Little Russia, Little India. And so people congregate amongst the ethnic groups, and all those different ethnic groups need to have their own doctors as well that usually tend to practice in those communities. So we need to train a more diverse group of surgeons that are expert also in earlier surgery, because with earlier surgery, earlier cataract surgery and microinvasive glaucoma surgery, we can cure early glaucoma, reduce the number of medications people need, and really bend the curve of blindness and preserving vision.
That's interesting, actually. I live in Vancouver in Canada. We have a fairly ethnically diverse community. My surgeon who did the cataract surgery for me is actually Chinese. And I think that when I was in the waiting room, he had a very mixed group of patients waiting. Lots of Caucasians were there as well.
Well, there's a couple of things. The Canadian system, you have a universal healthcare system. Everybody has health insurance. That's one.
Right.
Two, within the African American community in America, there's some distrust of the system because of a history of experimentation during the Tuskegee experiments. And persistent racism, frankly, that still exists. So and people like to see culturally competent care. They have to have faith in the doctor and faith in terms of what your intentions are. So those are obstacles that still have to be overcome in that respects. But having a diversity of surgeons and glaucoma specialists that reflect the population is extremely important. I mean, because people like to see culturally competent care and people they feel comfortable with. So that's important as well. But that's not to say that, non-African American physicians can't take care of African American patients, because that takes place all the time as well. But once again, because of the communities, the proximity, the fact that many of these institutions are located on the other side of town or across the other side of the railroad tracks, there are access issues with transportation, cost of transportation. It's one thing if you go to, how far is your doctor away from you?
Well, I walk everywhere. So he's across the water and probably a 20-minute walk from,
okay. So
from the
a
other
20-minute walk for you, okay, yeah, could be a 1-hour car drive for somebody else, okay, in terms of access to care. So there are, so because of where the resources are, where the doctor's offices are, and things of that nature, particularly for specialized care. That's why I opened my office specifically in Harlem and in Southeast Queens, right really in the heart of these communities, because I knew there was a shortage of physicians in there. And that's why, we're very busy and we're able to meet the needs of the people in that respect. But we need a lot more across the country in the United States, for example. And not just in the United States, but also in Southeast Asia, in China, and in Africa as well, which is extremely underserved as well, and in the Caribbean. Those are really hot spots for underserved areas in that respect. The Canadian system has a pretty robust system. Sometimes the care can take you a while to get you there, but it has a good, robust system. So I have good things to say about the Canadian system.
Now, you see, I'm in a very privileged situation. I'm living in urban downtown Vancouver. But we have some remote communities, a lot of remote communities, just thinking about British Columbia. And I'm wondering how good the access is to this kind of preventative checkup is in many of these communities. I don't know, but it's yes, we have universal care, but it isn't evenly distributed. I realize that you have your offices and all of that in that area. How do you what sort of actual outreach do you do? Do you go and sort of talk to, I don't know, groups within the community to tell them about it? Or is it word of mouth? What do you do to promote the people coming in for their checkup?
Well, being in the community, that's one. I'm right there. So there's easy access for people to come to our offices. That's one. Mm-hmm. Two, I educate each of my patients, particularly to make sure they get their families checked for glaucoma. And that's another way of getting information out there. Three, we write local articles in the local media. Okay. We have African-American newspapers like the Amsterdam News, African-American media, Roland Martin, Black News Network, and different things like that. So I try to focus on, what the community is looking at, what they're reading, because for example, we look at CNN and CNBC and things of this nature, but some homes don't have those cable networks and they may not access that information. Also social media, Facebook, I have YouTube. We put educational information there and screening information there. Advertising some of the different civic organizations that have certain functions in the community, whether it's the church or fraternities or sororities. We'll take ads out in their books to educate people about getting their eyes checked and things like that. So it's a real grassroots type of thing. And that's why it's nice, because when you're in the community, you could tap into the local activities of the community, the organizations, and develop relationships with the people and really connect and educate.
As an expert in interventional glaucoma, I understand that you've developed a number of innovative surgical techniques to lower intraocular pressure with improved safety. Could you maybe just give me an indication of what are the standard interventions that people would have, and then what are the innovations that you've introduced?
Okay. Right now, the standard of care in treating newly diagnosed patients with glaucoma, open-angle glaucoma, is to lower the pressure with eye drops like this. Okay. And you have different types of eye drops we will take 1 time, 2 times, 3 times a day to lower the pressure. The problem with these eye drops is that it doesn't really address the cause, what's causing the glaucoma. Okay. Mm-hmm. And with time, we know that by taking eye drops, your vision will still get worse over time. Okay.
I didn't know that.
Slowly but surely. I mean, because the thing is, and the main reason for that is because people often forget to take their eye drops. It's very hard to take eye drops 2 or 3 times a day and actually remember to do that all the time. And so when you forget or you run out, and particularly within the African-American community, these can be very expensive. And if you can't afford it and you can't buy it, your vision may get a little bit worse. So we've shifted gears. There's laser treatment that can be done, but laser treatment can destroy some of the tissue. And I'm not a big fan of that. And it doesn't last very long. It lasts maybe 1, 2, 3 years at the most, and then it wears off.
So what are you treating? The lens?
You're treating the drain in the eye, the drain, the trabecular meshwork.
Okay.
You're treating the drain with laser. There's ALT and SLT. That's very, very popular. People will do that, but it's more of a short-acting type of thing. And it can affect, if you want to do actual surgery in the drain of the eye, could affect the results of that in some studies. So I've shifted now my approach to earlier and initial surgery with early cataract surgery. So we take the lens out, okay? Because usually this large lens, when it gets larger, that's the major cause of the glaucoma. So by taking it out with cataract surgery is very safe. It takes about 5-10 minutes, 10 to 15 minutes. We do it in the hospital, you go home the same day. And while we take this by taking this cataract out, in a patient with glaucoma, that lowers the pressure by 5 points alone. Now, we have new microsurgical devices that look like this, and it's very thin with the needle right here, very, very thin. And we can open up the drain inside the eye, open up the trabecular meshwork while we're there at the time of cataract surgery. So it really doesn't add very much time to the surgery, maybe another 5 minutes. And that lowers the eye pressure another 2 or 3 points. And so if you can catch the glaucoma early enough, we can get people off of their eye drops. And we've published a couple of studies that show that when you do the surgery early enough, you can get about 80% of people off their eye drops, okay? Because you can preserve the anatomy of the drain. You can stop the large lens from taking up the space and damaging the drain and open the drain up. And so by doing that early and early, the average age of cataract surgery is 73 in the United States. The average age of glaucoma surgery is about 63. And now with this earlier surgery that we do here, we're getting closer to like 60, with the earlier cataract surgery and drain. And by doing this, you don't have to do more complicated glaucoma surgeries like trabeculectomy and glaucoma tube shunts. That's for more advanced glaucoma. We can avoid that by doing this earlier, safer surgery. So that's a new breakthrough that we're doing. We're doing that here in New York, and I talk about that in my lectures around the world. We have lectures and talks on my YouTube page about that, and that's the message you want to get out, to do earlier, safer surgery. Now, the key thing, you have to have a good surgeon. Not all ophthalmologists are good surgeons. Some ophthalmologists are medical ophthalmologists. They choose just to, treat with eye drops and not operate by their choice, and that's fine. But you want to have a good surgeon that's really good at doing this cataract surgery and microinvasive glaucoma surgery. You have some big names in Canada that do that as well. And so that's the key thing. Find someone that's comfortable with that, doing that earlier on. And that will really bend the curve of blindness from glaucoma.
Well, a couple of things. First of all, Dr. Laroche, I hate being average, but I have to confess that I had my cataract surgery at 73. So I didn't realize that the lens actually got bigger. I mean, I thought all that happened with cataract was that there was increasing opacity. So does enlargement of the lens always go together with cataract?
Not always. Some people, I have patients that are 80 years old, they have small cataracts, but their lens is not that large. Okay, and they have normal pressures of 15, and they're doing fine, and I don't operate on them because their pressure's okay, and they're actually doing okay with their small cataract. But I have young patients that have a clear lens, and it's a very large lens, okay, that's grown very large for their eye. So for me, for narrow angle and open angle, the most identifiable cause of that is the enlargement of the lens. But it doesn't occur in everybody. And so for me, but it does, I see in my glaucoma patients, they have an enlargement of the lens that's contributing to the elevated eye pressure. And in many of their cases, taking the lens out and opening up the drain works well for them.
Now, one of the things, it's a long time since I read this study, But I think the AREDS2 study was really aimed at seeing if you could delay progression of macular degeneration. But I do seem to remember that they also found that there was a lessening of cataract formation and development of cataract.
That's correct. That's correct.
Yeah.
With multivitamins, a healthy diet, healthy nutrition that does delay cataract formation, decrease exposure to sunlight, UV sunlight as well, reduces cataract formation. So healthy diet and healthy exercise can definitely delay and reduce cataract formation and reduce glaucoma as well, as I mentioned before. And that is probably in part and parcel related to the cataract part as well.
Yeah, it's interesting. I have my background is in pediatrics, medical biochemistry, but I was also a director of laboratory. So I'm very interested in the ability to be able to measure things. We say if it matters, measure it. And the company that I am associated with has a device that can measure the level of carotenoid antioxidants in a non-invasive, 30-second test of your skin. And the system was originally developed to be able to measure the carotenoid antioxidants like lutein and zeaxanthin in the macular area of the eye. And then through various iterations it evolved into a handheld device that we use to quantify our carotenoid antioxidant score. Really interesting because when I began taking these, particular eye formulas, I'm sure my score was fairly low, but I'm really assured of having my antioxidant protection, at least through the carotenoid, the fat-soluble antioxidants at a very high level because I'm able to measure it. Do you have, you've given us a lot of information. Do you have any specific takeaways if you were going to summarize like 1 to 5? What would you, I guess number 1 would be make sure you have a regular checkup. And is annually enough?
Yes, annually is enough because you want to see if you have anything. If you are found to have something like a cataract or glaucoma or retinopathy, then they may say come back every 6 months or every 4 months to monitor a little more closely to make sure it's not progressing. Most likely you may be observed a little closer and or under some early treatment that needs to be monitored. So that's one. Find a good doctor that you're comfortable with and that's skilled in managing a particular disorder that you have. If it's a macular condition you have, you may want to see a retina specialist. If it's glaucoma, a glaucoma specialist, cataract, a good cataract surgeon in that respects. So that's one, making sure you get your eye exam. 2, take care of your health. Make sure you get vaccinated, eat healthy, exercise, and take care of your mental health. Make sure you have a good group of friends that you could talk to, people you can communicate with, meditate to reduce your stress hormones and things of that nature, and relax. And then spread the word. Spread the word. Encourage your friends and family to get checked out and take care of themselves. Those are the big takeaways I would leave for now.
I have to say I have my 7 pillars of my roadmap for aging youthfully. In other words, extending health span, not lifespan. I do just about everything that I personally would recommend. But the one thing I have not been able to consistently do is meditate. I'm too impatient. And I guess this is something.
Let me give you a suggestion. And it doesn't have to be long. You can meditate for 2 minutes to start out with. Basically, you find a quiet area, maybe just play a song or quiet area, turn the lights off, close your eyes, take 60 deep breaths through your nose. And you just take 60 deep, slow breaths.
And that's it?
And you do that 60 times, okay? Mm-hmm. You'll feel like so much more relaxed. And the longer you can do that, the better. A simple thing like that just helps calm you down, helps lower your blood pressure. And you can check your blood pressure. Do a test, like check your blood pressure before, check it 10 minutes later after, and you'll see the difference. So just things like that can help. And then there's different ways you can do that with yoga, and there's DVDs on meditation, and you can find something. And just relaxing. I mean, just relaxing early in your bed and calming down, maybe reading a little book and just calming down. That's also a form of breathing, breathing through your nose, deeply through your mouth and relaxing. And just trying to get your mind off of the things from the day to declutter your mind. That helps with your health overall as well.
Sleep is obviously vital. My problem with trying to meditate before I go to sleep is I'm one of these people that head on the pillow and I'm out. So
that's good
really
too. Good sleep. Good sleep. Many hours of sleep is a good way to do it too.
Mm-hmm. Well, thank you very much, Dr. Laroche. I learned a lot from you. I thought I knew a fair amount about glaucoma, but you've taught me quite a bit different. So for anybody who wants to find out more, I will put the website and the Facebook link for Dr. Laroche in the show note. And thank you again.
Thank you for having me.